Good morning, friends. Welcome to this instruction course on maximizing outcomes in your practice in challenging cataract cases. I think this we have been doing for our last, I don't know how many years, but it's been quite a popular course across the country and in other parts of the world also. Along with me, I have my colleagues sitting here, Dr. Manpreet Kaur, who is Associate Professor in Dr. R.P. Center, AIMS, New Delhi. Dr. Subin Bhattacharjee, who has been an innovator, who is known for a Bhattacharjee ring, BX, and who's made India proud in the international forum. I have my young colleague, Dr. Shail Vasavada, replacing his father today in the presentation. Avay could not make it. Unfortunately, Dr. Boris could not make it this time to India. So we'll be awaiting his presence in subsequent conferences in future. Dr. Namrata Sharma, the Chairman Scientific Committee for this meeting, will be joining us very, very soon. And apart from this particular thing, I am Dr. Jeevan Titiyal, Chief Instructor for this course here. And we'll be starting with our guest lecture, the keynote address by none other than Eric Martin, who's come from all the way from Belgium, who's our guest for this APO AIOS conference 2025 in New Delhi. And he's been one of the leading cataract refractive surgery practitioner in Europe as well as world across in Belgium. And he's going to talk us today on the new concept of pairing the lenses, and it makes life possible with geometric and geometric plus to give an advantage to our patient in a way they become comfortable in terms in life, having the range of vision which we require for these patients also. Dr. Eric, all yours.
Thank you, Professor Titiel, for this kind invitation to give this keynote lecture. I'm very honored by that. I was also very pleased always to be in India and to be submerged in your very rich culture, and it's always a pleasure to be here. The subject of my keynote lecture today is pairing two light distribution profiles to create peak visual performance. This is my financial disclosure. I'm going to talk about the Vivinex geometric trifocal IOL family, which is one of the latest and greatest in our armamentarium. It is built on the Vivinex platform, which is a very established platform, and it has a non-apodized truncated refractive zone, and only in the middle, the 3.2 millimeters zone of this lens, you have the diffractive design. Outside of that is a refractive design, which makes that in dim light conditions when driving a car and so on, so there is less dysphotopsia and glare. It is fully preloaded, it's hydrophilic and glistening free, and because it's hydrophobic, of course, there are lower rates of PCO. What is unique about this platform is that there are two lenses, very almost equal, but there are some differences between them. You have the geometric, which is available in +10 to +30 diopters in 0.5 diopter increments. This is the same for the geometric plus. It has the same add power for intermediate and near, both platforms, +1.75, +3.5. The A constant is 119, and it is always delivered in the preloaded multi-cert injector, and the recommended incision size is 2.2 millimeters. Now, what is the difference? I said it's almost the same, but there is a difference. The geometric has more light distribution than the geometric plus for far and intermediate, and less for near. So the geometric plus gives more light distribution for near. So, and this is always delivered to the multi-cert injector, which a lot of our colleagues love because it's versatile. And as you can see, my nurse is preparing the lens while I'm finishing the cortical remnant removal. I stabilize the eye with my left hand through the paracentesis, and the lens is delivered in a very controlled way. The haptics will unfold slowly, so you can control it and with my second hand I place the lens in the bag, and then you can deliver it in the eye. When it's a toric, you can rotate it very easily. So you can see here that you can have the nozzle retracted, so you can deliver the lens in the bag, or you can the nozzle put forward, so you can only enter the corneal wound for those who want it. You have a screw part for those who love it, or a push part. It's up to you to decide how to deliver this lens in the bag. Now, what is so special about it? It's the pairing strategy, and it's completely different than mix and match. And I will explain to you how it works and which of the difference in quality of mix and match and pairing. So as I said, the geometric give a higher light distribution for distance and near, and the plus for the geometrics more for far and intermediate, and the geometric plus, of course, for near. How does this look like? So the focus curve is almost the same, and the only difference is the light distribution. Here you can see the difference for distance, so more for the geometric, and in the geometric plus group there is more light going for near. Now, how to prove that this is a very good strategy, this pairing strategy? This is a study led by Professor Kaimak in Düsseldorf in Germany, and it was a study performed in 10 different sites, 8 in Germany and 2 in Spain. So what did they do? They put 36 eyes, so 36 patients, both eyes geometric, 52 patients, both eyes geometric plus, and 36 mixing the geometric with the geometric plus. This was published in Clinical Ophthalmology recently in 2024, so last year. And 84% of the eyes showed a spherical equivalent with it half a diopter. So what did this study find? As you can see here, you can see the different defocus curves. When you implant the geometric in both eyes, or the geometric and the geometric plus, you have an as good distance vision as only the geometric in both eyes. For intermediate, it's slightly better when you implant both geometric lenses, and for near, the geometric plus in both eyes performs as good as the pairing strategy with geometric and geometric plus. So what does this mean is that when you pair the geometric and the geometric plus, you get a smooth transition from distance, intermediate to near, while having the same distance correction and the same near correction as using the geometric for far only or geometric plus for near only. So when combined, you can see this here, that what is the patient feedback on spectacle usage. When you pair the geometric and the geometric plus, 94.4% are spectacle free for distance, 97% for intermediate, and almost 92% for near. So impressive figures. So more than 90% of patients never use the glasses across all distances. So what is the conclusion of this study? That pairing those both lenses may be used either bilaterally or in a paired contralateral fashion to provide effective correction of presbyopia. So the mean values were 0.15 logmar with a defocus curve plus 0.5 to minus 3.5. And the concept of pairing these two lenses and not add powers ensures a continuous range of vision from far to close and near. Well, the thing is that the difference between pairing those two lenses and mixing and matching, what is the difference? Because you use the same lens, well, the same refractive index in both eyes, so the same profile, only the light distribution is different. There's the same chromatic aberration, so it's easy for the brain to pick up those images and form one image in the brain and have a binocular good vision. So by pairing those two, you get the most balanced combination for the highest spectacle independence at all distances. Now I will show you a few more complicated cases, because what we see is that a lot of patients we treated on 20, 30 years ago, post-LASIK, post-PRK cases, they come in now because they have reached the presbyopic age and they want to stay free of glasses. So this is the first patient I want to show you. It's a 56-year-old, had LASIK in 2009. It was performed by me for a -2. His best corrected digital visual acuity is still 20/20, but he needs reading glasses. So first, what do? We look at the topography map to see whether the LASIK procedure was nicely centered. That's very important, and that there are not too many higher order aberrations in the cornea. As you can see here, the total order aberrations are 0.14, which is very acceptable to go for trifocal IOL implantation. So almost two years ago, I did a bilateral sequential surgery. The geometric +20 was inserted in the right eye and the +20.5 geometric in the left eye. What were the results? After 1 month, the monocular uncorrected distance visual acuity was logMAR 0.1 in the right eye and 0.05 in the left eye. The intermediate vision was J3, and the uncorrected near visual acuity was J2. The binocular distance corrected visual acuity was 20/20. The patient was very satisfied with the outcomes, and you can be surprised, but he did not report halos, glare, or reduction of contrast. And it's also proven with this device, the higher order aberration aberrometer from CSO, where you can see that there's a very low amount of higher order aberrations in the total optical system. So the patient was very happy with this result. The second patient I want to show you is a 79 years old with anisometropia and astigmatism, and he wanted to be independent after surgery. The best corrected distance visual acuity was, of course, lower because of the cataract, 0.2 logMAR. I did a bilateral sequential surgery, putting in a Vivinec geometric toric plus 18.5 diopters in the right eye, T4, and a 17.5 T3 in the left eye, the geometric plus design. It's of course important to put the lens in the right axis, and therefore I use two devices. First of all, you can see here the markings in the cornea, which is done by the femtosecond laser. And secondly, I work with a microscope, which gives me a digital overlay where to put the lens. When those two are matching, I'm pretty sure I put the lens in the right position. The Vivinec platform, the Vivinec toric platform, is an established platform, and we know the stability, the toric stability is very high. So the geometric it's on the same platform. We also found that this platform is as stable as the monofocal Vivinec toric. What are the results 1 month after surgery? Monocular 0.05 logMAR, intermediate J1, and also for near J2. The binocular distance corrected visual acuity was slightly better than the monocular, 0.0 logMAR, and the patient was very happy with his vision and no glasses needed. Again, we checked for higher order aberrations. As you can see, the post-op refraction, because when you're dealing with those trifocal IOLs, you want to be within half a diopter of spherical equivalent and half a diopter of sphere and less than half a diopter of cylinder. This trace refraction gave me plano -1/4 at 135 degrees with a low amount of higher order total aberrations of 0.12. We also checked what was the implantation. The astigmatism was corrected in 98 degrees, in the cornea 91. So I could even improve this result by rotating the lens 7 degrees, and I could gain 0.23 diopters in cylindrical power. But of course the patient was satisfied, we did not do it. And the same thing for the left eye, 5 degrees of rotation could improve the astigmatism with 0.16. So in conclusion, we can say that the Vivinec geometric pairing combines two identical profiles. There is no need to identify the dominant eye. You can put the geometric plus in the distance dominant eye or the geometric. The Nino study proved that it doesn't make any difference. Because of the smaller diffractive design, the 3.2 millimeter in the center, there are less side effects and smooth transition for distance and for far and near. I thank you so much for your kind invitation.
Thank you so much, Eric, for a wonderful presentation. I think, this concept of giving more light to near and is really, significant improvement in the concept of giving better, brighter vision to most of them. And looking to your results, more than 92% people are free of spectacles in all distance. That's a wonderful result we have. Just in the meantime, I'll request Namrata to put up the presentation there. One query here: is there any dependence to pupil size? Have you studied the pupil size in relation to the advantage which we have in these patients?
Yes, there is dependency on pupil size.
Yeah.
The thing is, when you have a dim light and the pupil dilates, and you get more than 3.2 millimeters of pupil, you end up in the refractive zone of the lens, and that's why we find less halos and glare with these types of lenses. So this is very important to know, because we all know it's a trade-off. Multifocal designs give some decrease in contrast sensitivity, but with this design I found less than with other models of trifocal IOLs.
That means we are going to have more benefits in myopic conditions where pupil dilates a little more.
Yes.
Yeah. Very good. Any questions to Eric? Thank you, Eric, for being with us, and
thank you very much.
I hope you enjoyed stay in Delhi.
Yeah. Thank you very much. That's my pleasure.
Yeah, thank you. In the meantime, I'd like to invite Professor Namrata Sharma, because she has a lot of engagement, so she'll be presenting first. You all know she is our scientific committee chairperson. She's heading the cornea refractive ocular surface in RP Center, and she's going to talk us today about doing a effective phacoemulsification surgeries in those cases where cornea is compromised. I think we do see such patients quite often in our practice, and you have to know what are those important practical tips by which we can safeguard the corneal endothelium, or we can do a combined procedure in long run also. Professor Namrata Sharma.
Thank you, sir, and thank you for making me a part of this important instruction course. I would be talking to you about cataract surgery in corneal disorders, and there are no financial or proprietary interests. But I would be discussing the use of trypan blue dye and air. The factors which determine whether you would do a single stage procedure or combined procedure are the type of the corneal opacity, the location of the haze, the expertise of the surgeon, whether you want to do SICS or phaco, availability of the donor corneas, and visual requirement in terms of risk-benefit analysis. Most of the cases we do monofocal intraocular lens, keratometry and video keratography should be done. It is often not possible to do IOL master, so you have to depend on the B scan. You have to depend on the B scan for the biometry. First and foremost is you have to plan your incision. So depending upon where your opacity is, the incision is planned in such a manner that at least one half of the cornea is clear, so that from that part which is a little clearer, you are able to do your steps. So just to show examples, this part of the cornea is clear, so the incision that is planned is temporal. Trypan blue staining of the capsule is done, and just as you come underneath that haze, you have to go in one go, because if you lose it underneath that, it will become difficult to actually relocate it. Hydro maneuvers are done and followed by nuclear emulsification, irrigation and aspiration, and again copious hydro maneuvers should be done in these cases so that the disassembly is also easier. This is followed by the foldable intraocular lens implantation. Now this is the case where corneal opacity is there and cataract, which is hard, and optical iridectomy. Patient was one-eyed, so didn't want a corneal transplant surgery. So in this case again, trypan blue staining is done, and just as you come underneath this, you have to go in one go. Also notice sometimes you have to push the globe down so that you can see the edge of the rexus there. And as you come more into the clearer area, you do slightly eccentric rexus, because this is the area of working and this is also the area from the patient is going to see. So the technique which we do is crater and chop. So you just make these chops, and always remember to put your retro illumination on, because as you eat away the fragments, the glow will become clearer and clearer, and the contrast will get better between the grayish fragments and the red glow, so as which will allow you to see. And sometimes these fragments may be camouflaged underneath this opacity, so you have to, with the help of the second instrument, put it back into the phacoemulsification probe or into the irrigation aspiration probe, and then subsequently a foldable intraocular lens implantation is done. And just as you implant the lens, the view becomes a lot clearer, because all the refractive error gets neutralized. So we did publish our results of cataract with ocular SJS, and we've done some difficult cases, because SJS is a high risk for keratoplasty, so you can't do corneal transplantation. So notice nylon hooks have been used to expand the pupil. Endo-illuminator is being used inside so that you can see where you have to chop, and now endo-illuminator is being used outside to see where the edge of the rexus is, so that the lens can be put in the bag in these cases. Some of the results pre and post-op. So the patients don't get very good quality of vision, but they do become ambulatory, and especially if you're not planning a transplant for reasons of high risk, then this is a good method of dealing with it. So these are some of the cases pre and post-op. The visual acuity here is 20/30. Here it is less, but still better than what the patient was earlier, which is hand movements close to face. And again, in this, the haze is there, but these patients, if you do transplants, they are bound to fail in SJS. Then in our experience, flax also has a very important role to play in corneal haze, because in the areas where the haze is present, it is not going to cut, but in the areas where the haze is not going to present, it is going to cut. So it's like fill in the blanks. So it will do the rexus, but not do completely. But you can just fill the blank where it has not done it. Likewise for chops also. And it does make things easier for you, because you are able to do it, provided it's not so hazy that even flax cannot be done. So this is one case to show that, and this is the second case. Like I said, the technique is fill in the blanks technique. So in this case, again, notice that this chop is not complete, and the rexus here is not done by femto. So all you have to do is, you have to fill this blank and also fill the blank of the chop, and then subsequently do the surgery, which then becomes easy. And as soon as you put the intraocular lens in these cases, notice that it becomes very clear. In cases where you do have anterior corneal opacity, you may have to combine it with ALTK. Like in this case, there is a healed keratitis with spheroidal degeneration. So the anterior part of the cornea is removed, then subsequently the phacoemulsification and irrigation aspiration is done. The intraocular lens is implanted, and then the anterior lamellar graft is taken, is then sutured onto the host. Now this was yet another case of chemical injury, where actually we had planned to do only deep anterior lamellar keratoplasty, but as we went down, we saw that there was a cataract present. So again, we are doing cataract surgery in this case. Phacoemulsification is done, and viscoelastic is again put, and the last layer is removed after you've done the intraocular lens implantation, and then subsequently, again in these cases, from the pre-op, the post-op visual considerably improves. This is a classic case of Fuchs dystrophy with cataract, which actually had a hypertrophic epithelium, which was removed. Subsequently, there was a scarred Descemet's membrane also, which was stained with the trypan blue dye, and it was removed because this case was planned for this DSEC triple. So this is the second rexus, and the third rexus was when the anterior capsule was stained, and this was also removed. Subsequently, the phacoemulsification and irrigation aspiration was done, followed by foldable intraocular lens implantation, and the DSEC lenticule, which was then pulled intracamerally. Air bubble was instilled, graft was centered, and this is now almost 7 years down the follow-up. Patient is doing well, and you didn't have to do a corneal transplant. Then again, in cases of Fuchs dystrophy with cataract, you can also do DMEC like we did in this case, and this is the picture at the last follow-up with the visual acuity which is 20/20 or 6/6. Now coming to post-keratoplasty phacoemulsification, this was a case in which tuck-in lamellar keratoplasty has been done. It is a deep anterior lamellar keratoplasty. So in these cases, the trypan blue staining of the anterior capsule is done, and after doing the trypan blue staining of the anterior capsule, the nuclear emulsification is done, followed by irrigation and aspiration, and subsequently the foldable intraocular lens is implanted. Important thing is, in this case, you should not have a interface, you should not, the graft should be opposed, and notice here that as you put the intraocular lens, the graft has actually got detached. So this is what we visualized on the intraop OCT microscope, and then subsequently we drained the fluid from in between the graft and the overlying host, and then injected the air bubble, and now the graft is also pretty attached. This was a case of post-PK phacoemulsification for which toric intraocular lens implantation has been done, and in this case the IOL power calculation is a challenge. Again, the steps of the surgery are same as we would do normal phacoemulsification with irrigation, aspiration, and foldable intraocular lens implantation. And because this was a toric lens, the toric intraocular lens was used in this case. Now this is a case of post-PK DSEC. That means after doing penetrating keratoplasty, we did a DSEC, and then the patient developed a cataract. So you can see that this is the PK graft where the graft host junction is there, and this is the DSEC graft which is stuck to the back of the cornea. And again, in these such cases, it is important to see that the graft does not get detached. There's no big deal about doing phacoemulsification surgery because the steps remain essentially the same. Notice that the DSEC graft is pretty much attached, and this is the post-PK graft host junction. So this is a post-PK DSEC cataract in which the foldable intraocular lens implantation is being done. And again, you have to see that there's some gap which is there as you place the intraocular lens. And if you have the intraop OCT microscope, you can see that the graft is getting a little unzipped. So at the end of the surgery, you have to put the air bubble so that the graft, after putting the aspiration and putting the air bubble, will get attached to the penetrating keratoplasty which had been done earlier. So I think this is the algorithm we follow. If there's a cataract surgery with corneal opacity, you can do phaco alone, provided the corneal opacity is small and only partially involving the visual axis. You may even attempt to do an optical iridectomy or even PTK, but sometimes you have to do combined procedures if the opacity is deeper. Depending upon what level it is, you can do superficial anterior lamellar keratoplasty, deep anterior lamellar keratoplasty, a DSEC or a DMEC triple, depending upon if only the endothelium is involved, or a DALC triple if only the anterior layers are involved, or if all the layers are involved, then you have to do a PKP triple. So this is our review article which was published in Journal of Cataract and Refractive Surgery on phaco with coexisting corneal opacities. And I think this has come again, sorry about that. So to conclude, when you are doing phacoemulsification and corneal opacities, these are the dictums: finding, seeing, creating, and filling the gaps. So incision placement is important, capsulorhexis should be eccentric, copious hydro procedures, crater can be eccentric, chops can be done, you may have to do sphincterotomy or optical iridectomy. When you are working on the operating microscope, the retro illumination has to be on, don't forget to do it because that helps you to get the contrast better. You may need nylon hooks, trypan blue dye is important, dispersive OBD should be used, BSS plus should be used. The fluidic parameters can be low, and you have to counsel the patients that in all those cases which are high risk grafts, you'll do phacoemulsification first. If they're good prognosis for graft, you can do combined procedures, and always counsel the patient that what we are aiming at is ambulatory visual acuity. We may not be aiming at an eagle's eye vision of 6/6 or 6/5, but we are trying to make the patient ambulatory and doing whatever is the best in those circumstances. Thank you so much for your kind attention.
Thank you, Dr. Namrata. Wonderful presentation. Just few queries for our people to understand, because these are difficult cases. Sometimes you have the poor ocular surface, the surgery may be prolonged, you may be combined. Any tips, how do we safeguard the ocular surface or a corneal epithelium during the surgery in these cases, also to highlight the visibility in those cases, Namrata?
So I think I missed that on my
No, no,
videos,
please,
but
please.
because I moved them fast. So important thing is that you should put OVD, something like a Vislon or HPMC on the corneal surface. So as soon as you put that, the visibility will become a lot more clearer, and also for that split of a second it will get magnified. So it will allow you to actually do the steps. Suppose you can't see the rexes, you put a blob of viscoelastic, it will get magnified, and then visibility will also improve.
Second, suppose we've done a phaco in these difficult cases. Any alteration in the post-op management compared to your routine cataract patients?
So I think post-op you have to be looking at two things again, the epithelium and the endothelium, which are very important from cornea surgeon's point of view. So for promoting the epithelialization, it is good to give lubricants in these cases, ideally which is sodium hyaluronate based. And also you have to see that there is no corneal edema, because for that these most of them would have a compromised endothelium, and for that you would need to give sodium chloride drops or sodium chloride ointment, and sometimes even rho kinase inhibitors.
Yeah, yeah. Now, like during the cataract surgery, you saw a beautiful surgery. Any tips for them to protect the endothelium in a compromised cases?
So I think dispersive viscoelastic at no financial interest, but I tend to use a lot of viscoat in these cases so that the cornea remains coated with the OVD.
Other, important, I keep getting these questions to me also, sometimes difficult to answer. Like, suppose we have done a DALK and a patient has a cataract and patient has, 3 diopter cylinder. Would you put toric in this patient? Similarly, for a PKP patient where you have the, now you have to do cataract, would you go for premium IOL, like suppose toric IOL? Suppose we need to do a regraft subsequently, how would this be, situation can be managed?
So for cases where the astigmatism is say 3 diopters, I think most important for these cases would be that you have to do a corneal topography, pentacam or whatever topography you have, and have to assess how much is the regular astigmatism and how much is the irregular astigmatism. So regular astigmatism is something that you can take care of, but irregular you cannot take care of. And whatever the regular astigmatism is, that should be addressed with a toric IOL. But one should be very clear that you will not be able to address the complete astigmatism or entire astigmatism, because the component of irregular astigmatism will remain in those cases. So I would still go in for a toric IOL, but regarding the multifocal IOL, I don't think I will use it, because you have a multifocal IOL and then you have almost a multifocal cornea, so that you don't know how it is going to behave. Extended depth of focus lenses I will use in these cases, but I have started to
You are
use
trying
in
to
these
impress people, huh?
started to use in these cases, but I think monofocal, not done a study to compare monofocal and EDOF, but on an extrapolation that they wouldn't decrease contrast sensitivity, have started using, but not use multifocal in these cases at all.
Can you have the mic? She's saying something. Okay, she's asking what about pinhole IOL? Do you have experience in that?
So I don't have experience with pinhole IOL, and pinhole pupilloplastic corneal surgeons I think do very less, because we like to address everything on the cornea, pathology of the cornea, by treating the cornea rather than doing a pinhole pupilloplasty. And pinhole will give you a vision, but I've not done very many, but I tend to think that the field might be a little compromised, or even if the field is there, in case they require some procedure later on, because all these eyes are anyway compromised, then dilatation may be a little problem.
Especially if they have a some retinal pathology, then it's very difficult. You have to undo the, all these pinhole pupilloplasty, then do those procedures. And these cases may be access compromise. They may require, assessment of a posterior segment, and many times the things can be very tough sometimes. On a desperation, maybe yes. Although we have so many options to create of.
No, sometimes pinhole also will not work, because of the simple reason, because of the corneal opacity of the haze, there's so much of diffraction which is going on, and if you give a pinhole, probably that is the area from where the patient is seeing also. So where will the pinhole be? Yeah, yeah.
Overall light. Okay.
The refractive error may be corrected, but the overall quantum of light. So if we are seeing it as a bright daylight, it will be probably sunset for the patient.
I think it's a good concept to have a pinhole so that all the unfiltered light is not there. You have a parallel light going to the fovea. You can see better. But pinhole IOL is a good concept because you can still dilate, you can still assess the peripheral area, but these lenses are not available per se and never had become a popular also, like our presbyopic correction. Thank you, Professor Namrata, for giving these very important tips. Let me take you through the new concept in any surgery in the body where imaging has become an important part. Today, if you have a headache, you have abdominal pain, you have to go through CT scan, MRIs. The same thing has happened to ocular pathologies also. We all had the concept of imaging and retinal procedures before doing any other interventions. Same thing I like to stress on, the imaging is a very important part in cataract surgery also to enhance your safety and also look into as such when you're doing surgery, what are the various dynamics which can happen, which can change your concept of visualization during surgery is so important in these cases also. This is what we have been doing regularly. We have been telling our students to examine your patient very, very carefully, do good selective examination. This is a white cataract. Look for anterior bulge of a capsule, that is a sphericity of convexity of anterior capsule. Look for anterior chamber space, especially peripheral areas, because periphery can be so shallow sometimes, it may be difficult to enter. Look for intralenticular clefts, and these are important guidelines. But if you do same patient under anterior segment OCT, which most of us have, the assessment is needed in these cases. You can document this patient appropriately, the anterior convexity, the fiber, the clefts, everything can be seen in these patients. In fact, you can define better, which may not be, sometimes difficult to replicate the examination by two examiners the same way. But OCT picture, if you have, you can have time, you can assess these patients appropriately, plan your surgery accordingly also. So we do have various methods to see the entire morphology of cornea, cataract, lens, and other areas also. You have a pre-op anterior segment OCTs, high definition one we have nowadays. Intraoperatively, if you have intraop microscope which has the OCT attachments, or if you are using a femtosecond laser devices, they have all OCT related pictures which can again image your entire profile of the anterior segment in these cases also. This is our review article on microscope integrated OCT in cataract surgery. This was important at that stage because everybody was talking about IOCT microscope is meant for only for retina people. So we shifted the concept that it is good for anterior segment surgery. In fact, now it is more used for anterior segment surgery than a posterior segment pathology also. The other important thing we realized while using the intraop microscope was it makes you to understand the changes happening with each step of your surgery. Suppose I make an incision, I can see the incision right from the beginning to end, which was not possible earlier. You could see the incision next day when you do anterior segment OCT, that you have distorted, you are damaged, you have a decimal moment detachment. That was only possible after next day if you take the patient to anterior segment OCT. This entire thing you can see now. You have done a uniplanar, biplanar, triplanar incision can be seen beautifully here. And most importantly, it is very helpful in challenging cases. Let me take you through two important areas of cataract, which is white and posterior polar cataract. White cataract, you all know, because of absence of red reflex, the rexus becomes very, very difficult, challenging. That is one part. Second part is we don't know which are those cases where actually you have an increased lenticular pressure. That is also important. If you realize that before surgery, you can plan your surgery accordingly. You can do aspiration with needle, you can do a puncture, you can do different types of application like femtosecond, Jepto, or a capsule laser can be planned in these cases also. So this publication came in late 2000, I think 19 or 20, where we classified the entire gamut of white cataracts by doing the intraop OCT imaging for these cases. We classified them into four categories, but you have the spectrum of white cataracts in between these categories also. The advantage of this classification was you could make your surgery according to this. I know that not everybody will have an intraop OCT microscope, but this image is replicated by anti-segment OCT. In fact, this is replicated by slit-lamp examination also. So if you understand this, you can replicate this into your practice very effectively also. So this was based on the two important areas. One was before intervention, second was after intervention. So we looked into convexity of anterior capsule, looked for arrangement of fibers, lamellas, and looked for an intra-fiber clefts in these cases or a homogeneity of fluid in these cases. Second part was the dynamicity, that is flattening of anterior lens capsule after injection of viscoelastic. What happens, how much flattening happens, the dynamicity of initiation of initial nick or a capsular axis, the disturbance of underlying cortex and release of fluid, which may be milky, which may be turbid, which may be no fluid also. Based on that, we did a classification. This imaging gave us the idea what should be done. Like this patient has a very regularly arranged lamellar cortical fibers, no clefts in this. Everything is very homogeneous. It seems that there may not be increased lenticular pressure. You can just see once we make an initiation of capsular axis, nothing happens, no fluid release. So this patient, you can rightly do a normal capsular axis. You don't have to intervene with any other procedure by going through the needle aspiration or doing other devices. This is a good case for a femtosecond laser application also. This was type 1. Type 2, we classified them, which is normally in a younger age group patients, where you have intumescence, hydrated lenticular fibers going across the length of a lens, right from the one end to other end, and you have thick cortical fibers, and the clefts are underneath that. In this particular case, as you initiate the opening here, the entire fiber bulge out. They don't let the fluid release because the pockets are underneath these thick fibers. And these are the cases where peripheral extension very, very high. If you go little more peripheral, the extension is 100% in these cases. What is to be done here? Make a smaller opening and aspirate this with the bimanual cannula, what you see in this video. In fact, this video won a best of show in American Academy a way back, I think 5-6 years back. So I'm seeing that this is a bulge which has occurred. I'm really afraid now. I have to block the peripheral area, inject little bit of dispersive viscoelastic which maintains the pressure, then make a small opening, aspirate now with a bimanual aspirator. That will decrease the pressure by making this convexity to concavity. Now you can fashion the rexis accordingly, comfortably with micro forceps or a needle also to a size where you can do a nice nucleotomy and implantation in these cases. The thing to learn here was, if you have thick fibers, needle aspiration may not work. There you have to break these fibers, so require a larger aspiration with cannulas. This is a type 3 where you have a combination of hydrated fibers, clefts, and little fluid. In fact, these group of cases are maximum we see in a younger patient also. As soon as you make a nick, there's a release of turbid fluid, sometimes like an oily fluid in a little amount. Even that little amount release causes a decrease in the pressure of a lenticular pressure, and you can do a normal area. I feel this is the case where needle aspiration really very helpful in these cases because you can aspirate the fluid very effectively, and rexis becomes very, very comfortable in these cases. Type 4 is totally filled with the fluid. This is going towards a hypermaturity or Morganian cataract. You make a nick and entire milky fluid comes out, pressure goes down immediately. So this particular case, even you don't do anything, nothing will happen because initial nick also will release the fluid. Only thing, the initial nick has to be very, very small. Don't make a larger nick, otherwise this release will block the visibility and sometimes the tear can extend. Make sure entire fluid is taken off before you initiate the rexis, good staining, and sometimes you may have to maintain the pressure of capsule to be torn. You may have to inject viscoelastic underneath this also. So this classification can also be seen in the femtosecond laser devices also. You can see while looking for a OCT picture in a femtosecond, you can see the entire configuration. You can homogeneous ground glass appearance there, which may be type 3 or type 4 type of picture. But if you apply the laser, the fluid will get released in this particular case. You can see the fluid is under pressure, it will get released at the breast. So that can also be seen that I know that this particular patient will have a gust of fluid release. In the operation table, I'll have to stain the capsule and take out the capsule in a manner where normally you do a capsular rexis in these cases. And you can see the thick cortical fibers are not broken even with the laser application. So we have to be a little careful in these cases, even after application of femtosecond laser in these cases also. So this is a classification which gives us the idea that you have to see, and accordingly you can manage these group of cases. In fact, now we normally look all these cases through anti-segment OCT before we take up for surgery for these cases. Look for a type of white cataract you have, and look for a intralenticular pressure rise. Then, if possible, image them and do surgery accordingly. So what we have learned in the white cataract is all white cataracts may not have a raised lenticular pressure. It depends on its morphology per se. The second part which I'm going to take you through is the posterior polar cataract, where we have done a lot of studies also. And there also we are not sure which are those cases where actual posterior capsule can be weak or opened up before surgery also. These are various pictures you can see of posterior polar cataract classically seen. There also we have to see the important morphology which can be high risk factors. So this is a study published by one of my younger colleagues where we did consecutive 100 cases of posterior polar cataract. We did an anti-segment OCT and seen with a high definition, seen the configuration morphology of these cases. So we realized there are three important features. This feature you can see in a slit lamp also. So if you have a conical shape, this is the posterior polar disc, and the entire posterior part is a conical shape. This is moth-eaten appearance, and this is the eclectic appearance. These three morphology in anti-segment OCTs are classified as high-risk cases. This we say because if you have these morphology, which is seen around 10% of cases, you have very high chances of posterior capsular opening during the surgery. Remaining 90% of cases have a generalized morphology, where the chances of posterior capsular opening is very, very less. This is what we always debate, should we do a hydrodissection or not? I can say if you have this morphology, then you should never do hydrodissection. But if you have a generalized morphology, you may be able to do hydrodissection, and surgery becomes simpler and faster in these cases also. Similarly, we had more than 40 patients where we did an intra-op OCT guided classification in a similar way, where we looked into a clarity or a delineation of a posterior capsule underneath the disc of a posterior polar cataract. If you could delineate the capsule centrally also, this is type 1. And if you could not delineate the central area, that is type 2, periphery could be delineated. And this all depends on a size and the thickness of a posterior polar cataract in the central area also. Just to show this type 2 variety where we don't do normally the hydrodissection, we are doing a delineation here. See what happens after delineation. There's a fluid here. This is endonucleus. This is the epicortical cushion we have created here. Decompress, the fluid will go off, which is very important in cases with posterior polar cataract. In this particular case, the second fluid wave went to a hydrodissection phase. You can see there is some hydrodissection happen. So even you have a hydrodissection, when you are doing actual surgery, don't try to rotate the entire complex. Try to just handle the endonucleus only. In that way, you can safeguard your posterior capsule in these patients also. Type 3 is a moth-eaten appearance in anti-segment OCT. Here you can see you cannot delineate the entire range of a posterior capsule, and surgery can be very difficult here. These are cases, they have a harder nucleus. Even a delineation becomes difficult in these cases also. So this is a more challenging, and the technique of the internal hydrodelineation may be very useful in this group of case where the actual delineation doesn't happen completely. So after we make a trench divide, then the delineation can happen in these cases also. So there, if you don't have to do a hydrodissection, don't have to rotate your nucleus, then this technique of ours, chop and tubble nucleotomy technique published in IGO, is very, very effective way. So this is a delineation now we are doing, which is separate the nucleus core from the epicortical area. And like this is the core now, this is the epinuclear cushion, and the entire surgery is related to this central core only till you effectively eat out this. If you see here, we have done just a delineation. Central area is now created. This space will allow the internal hydrodelineation happen. This is the space here. The fluid shifts around surrounding area to create multiple delineation. and surgery subsequently become very, very effective also. Now, I can just pull the piece to the center. You can see this is without disrupting the epicortical cushion. I have selectively delineated the core of a nucleus to center, and this is safeguards the posterior capsule. You follow this technique, you'll never have a posterior capsule opening during your surgery. It might open up subsequently when you take out the epicortical cushion, and that is not going to give you any drop in the nucleus to the posterior capsule. This is the enhancement of visibility with the femtosecond laser. This is the posterior polar cataract. You can scan the posterior part also. This is our technique after Avay talked about rings of safety. We combine this with the chops also. The hybrid technique, 3 rings of delineation and 8 chops gives you 3 layers of blocks of nucleus. This is one primary, secondary, tertiary with epinucleus, and surgery becomes very, very effective in these cases also. So how you can see this imaging changes your concept of surgery is very important. And this is what I talked about. You can see what type of incision you have done initially with the OCT microscope. What happens after your hydro procedures? What happens after your nucleotomy, irrigation, aspiration, implantation? And you can assess the most important area, that is near the incision, the wound side detachment, which can happen, which can extend also. This is another classical video I have from one of my patient with interdigital compromise case, Fuchs case. I've done a phaco effectively in this patient. With the hazy cornea, implanted the IOL monofocal lens. And when I was doing hydration in this particular case, I realized this is one side, this other side. Little bit of frill I could see when I hydration here. I opened up my OCT microscope. I could realize there's a wound side decimal detachment. I thought, let me shift this cursor little towards the corneal side. I realized the detachment was quite big. So if I had no OCT picture, I would have left like this, and next day entire decimal would have detached. You can see how big is the detachment here. The imaging in such cases is very, very important and really saves the day for you. And with air injection, for keeping that for another 3 to 5 minutes, the detachment got settled down, and next day patients are all right. So I can summarize this. Please don't think that I am just showing the IOCT microscope. Replicate that image to OCT, anti-segment OCT imaging. Replicate that to your straight-time examination. You'll do better in your surgeries. So it is very useful in corneal surgeries, useful in assessing the wound areas, useful in a refractive surgery like smile, lenticle-based surgeries, as well as ICLs also. Cataract surgery, yes, it is very, very definitely advantageous to image your cases before surgery, intraoperatively, and postoperatively also, and change your concept. Thank you for your kind listening for this talk.
Thank you, sir. We now have Dr. Shail Vasavada, who will be taking us through phacoemulsification in posterior polar cataracts and pre-existing posterior capsular defect.
Thank you very much, sir, and Dr. Manpreet for allowing me to be a part of this course. And after that masterclass from sir, it's very difficult to tell you anything extra. So this was a case of posterior polar cataract with a pre-existing defect. So this girl was a 27-year-old girl who had a unilateral posterior polar cataract with a pre-existing defect. The other eye was normal. So as you can see here, this is this polar, along with, when you see all of these extensions around it, there is a high possibility of a rupture. And with the flax, we did find that there is a gap in the posterior capsule, which means there is a pre-existing defect. And you can also see some particles in the anterior vitreous phase. Now we prefer to do what we published, femtodelineation, which means multiple areas of epinuclear cushions. And these are the cases where even if you are not used to working at low parameters, you want to do at low parameters. So I've kept my IOP only at 30, which is equivalent to a bottle height of about 45 centimeters. And notice what we are doing here is now we are detaching this epinucleus from the foreign eyes without actually removing it completely. So what this does is it now creates a communication between the anterior and the posterior compartments, which means it will allow fluid to trickle down. And now if you have a thick epinuclear plate, and even if you now go back and do hydrodissection, there won't be any raised intralenticular pressure which will lead to rupture. So this is what Dr. Bobby Osher described very nicely as the escape sign, which means you detach it from the fornix and then let it be there. Don't try and remove it completely, so that it will allow small aliquots of fluid passing through. And at all times try and stay in the center. So we are making sure that until the last point, the entire central posterior polar part is not affected, because the aim here is that there is a pre-existing defect, but you want to try and make sure that it doesn't extend further or it doesn't cause to a drop nucleus. So that's what we are looking at. Making sure that you have a very relatively low flow rate that is there. Again, another very important point is to maintain a closed chamber, which Dr. Bobby Osher once again taught us, is that before withdrawing any of your instruments or withdrawing fluid, don't allow the chamber to decompress, or the lens zonular complex to move forward. So even if you are not normally using dispersive viscoelastic, this is the case where you want to keep the dispersive viscoelastic ready, because dispersive viscoelastic is retentive. Unlike cohesive, which comes out in one bolus the moment you immediately remove the irrigation. So inject dispersive viscoelastic with your other hand before actually removing the phaco probe. This is definitely the case for bimanual irrigation aspiration, so that the main wound valve is not disturbed, and you can ergonomically access both sides without having to cause too much of manipulation of the wound and wound leakage to occur. So fortunately, so far we have been able to kind of preserve this pre-existing defect. Even when you change your hands for bimanual irrigation aspiration from one side to the other, you have to inject dispersive viscoelastic, because any shallowing will lead to a sudden rupture or sudden extension of this pre-existing tear. So fortunately, having followed all the principles, now we are in this situation with this pre-existing tear, which has fortunately not extended, and there is also significant plaque and some, as you can see, particles in the anterior vitreous phase. Now this patient also had very high astigmatism. So we had explained to her that if we are able to preserve the bag and preserve the posterior capsule, we may consider doing a toric IOL, but otherwise we'll go ahead with a 3-piece monofocal IOL. So we still, since the tear has not extended beyond the rex's margin or up to the equator, we have a chance to salvage this situation. So now we are trying to convert this pre-existing tear into a posterior capsulorhexis, because we know that if we can convert it into a capsulorhexis, this will act as a strong platform on which you can place in the bag IOL. I would strongly recommend the use of micro-incision capsulorhexis forceps, and you need to change your hands according to the forces that you need to put. So if you want to approach this side, go from this side port and pull circumferentially as well as upwards, so that it doesn't go forwards. And what I'm trying to do is not only create it into a PCCC, but also encompass that posterior capsule plaque, so that the patient can have a clear visual axis post-operatively. So slowly but surely, after changing hands, we've been able to convert it into a PCCC. Always confirm the presence of vitreous by injecting triamcinolone, and although there was none in the anterior chamber, because there was little bit of muck, all the particles that you saw in the very anterior vitreous phase, we decided to remove that. And this is the end picture. This is the anterior capsulorhexis, this is the posterior capsulorhexis, and therefore now we have a strong platform on which we can place a high toric correction IOL, a T7 in this case. We are going ahead and injecting this IOL under cohesive viscoelastic and making sure that it opens slowly and unfolds inside the bag, and then aligning it to its appropriate position. Now obviously you are not going to go behind the IOL to remove the viscoelastic in such cases, and therefore you can give mannitol to these patients post-operatively. Again, in the end, confirm that there is no further vitreous disturbance with your IOL manipulations. And also don't forget this step. Before withdrawing the irrigation, form the chamber by hydrating the wounds, and this is the end picture, and this is the patient at 2 weeks and has done very well for the past 1 year as well, with the toric not rotating and a central clear visual axis. Now this is another case of a classic posterior polar, and when you
Shall, just a minute. When you are doing the primary capsular axis in a posterior capsule, any trick advice how to inject viscoelastic in these cases so that posterior capsule doesn't go back too much backwards?
Yes, sir. So I think the trick here is not to actually inject too much in the center of the posterior capsule. So inject more in the mid periphery so that your central area of opening doesn't get too deep, because if it gets too deep you find difficult reaching it, and then you end up grabbing the vitreous fibers along with the capsule. So inject more in the mid periphery so that there is not too much of pressure, and you can approach it appropriately, sir.
Thank you so much.
Right.
But can people who are not very versed with the this primary capsular access, can they do with a vitrector also if they have the access to vitrector?
So vitrectorexis can be done, but vitrectorexis isn't always very predictable. So very often it can split immediately the moment you try and touch one area, and the rexis margin also sometimes isn't very strong.
Yes.
So although it appears circular, when you inject the IOL and manipulate it, it tends to split away. So if you are not confident, or if you think the tear is too large, safest is to do a 3-piece IOL haptics in the sulcus and capture it through ACCC.
And also you can disrupt the anterior vitreous phase, because
Absolutely.
there will be a fluid also,
Absolutely.
and it's a very difficult proposition. So if you can do a capsular access, very good.
Right.
Yeah, Doctor.
Yes.
Okay.
Very true, sir.
So you can tell us later when you are presenting again.
Yeah.
Thank you.
So so this is the second case of a large posterior polar, and you can see this defect already pre-existing in this patient. So he also had a reasonably dense nuclear cataract. So this is the very high risk case, and this is the case where if you are slightest doubt, I would first of all suggest a peribulbar anesthesia. So we like to do the cylindrical lens division pattern, and quite often in these dense cataracts, like Dr. Titial sir correctly showed, and in his publication, you may need to separate the endonucleus because it's a very, very dense cataract. So it's unlike a soft posterior polar of a very young person. This is not going to flip out just by rotating or just by aspiration. So here I'm struggling, to be honest. I couldn't create a decent enough crack. So what I'm doing is I'm sculpting and thinning out this entire central zone so that I can create a reasonable bowl, thinnish bowl, which I can kind of try and prolapse. And once again, I'm trying to make sure that I'm creating this communication between the anterior and the posterior compartment, which will allow me that now with this thick epinucleus, even if I have to, I can now do small aliquots of hydrodissection in these areas so that I can manipulate the epinuclear plate towards the center. Quite often when you create this separation, some auto hydrodissection also tends to occur, and you need not always have to do anything. Like in this case, fortunately it did come out on its own, but at this point you can always go back and do gentle hydrodissections in these specific areas. Always try and remain in the center with low bottle height and a low flow rate, and fortunately we were able to avoid a drop nucleus. So now we have this situation where we have this classical vertical tear which is extending from equator to equator. Fortunately the dense nucleus, central nucleus, is out, but we also have cortex remaining at this point of time. What I've always found is that whenever there is a very large opening and whenever there is doubt of vitreous presence, the best is to tackle it at that point of time. So what I've done is that although this was a 2.2 incision, I've sutured that wound because I like to approach the vitreous from the pars plana, and to insert a trocar you need the eye to be firm. So I've sutured the 2.2 incision, and I've kept the irrigation handpiece on continuous mode in the left hand with a relatively higher IOP, so that there is reasonable pressure to insert the trocar. And then this is what we typically describe as bimanual vitrectomy, which means irrigation from the front, maximum cut rate that your machine offers, low bottle height of 20 cc and a very low flow rate of 10 cc per minute, and an appropriate vacuum of around 250 to 300, and remove the vitreous from the area of the pre-existing defect and all around. Once that is done, you can then go back to your bimanual irrigation aspiration, because there is no fear of catching any vitreous as you have removed it symmetrically from both sides. And definitely make sure that all the cortex is removed by swapping your hands from one side to the other as and when required. So This is the end picture. Fortunately, the capsular axis is strong and centered due to the flags, and end-to-end vertical, fairly large posterior capsular dehiscence. So this is definitely not the eye where I'm thinking of in the bag IOL implantation, because I'm not sure about the stability of the IOL, and therefore in such situations our preference is to go ahead with a 3-piece IOL. So now I'm first of all making sure that after all of these maneuvers there is no further vitreous disturbance, and it's always a good idea to remove some vitreous from around the posterior capsular tear, so it allows a symmetrical scaffold for IOL implantation. And now I'm going ahead and injecting cohesive viscoelastic. I've enlarged my incision to a 3.2 millimeter incision. Injecting a 3-piece can sometimes be very tricky, so be very careful. This haptic was, threatening to go through the anterior and the posterior capsular axis. So keep an eye on that and make sure that the haptics go in the sulcus. And once they go into the sulcus, you can make sure that you can capture this optic through the anterior capsular axis behind. So once it's now stable and centered, I'm making sure and confirming that the haptics are in the sulcus by retracting the iris and making sure that this dumbbell kind of appearance does appear, which means that the optic is captured nicely through the anterior capsular axis. Also in the end, if there is any vitreous disturbance, make sure that you remove it completely. Suture the wounds in such situations, and this is how the patient did. Very well centered 3-piece IOL captured and a clear visual axis, and doing well at the end of several months. These eyes are prone to get macular edema and get the peripheral retinal evaluation also done, and this is the UBM to show that the IOL is well away behind the anterior capsular axis, well away from the iris. So I think the important pearls are femtodelineation does help, which means creating multiple delineations, and our rupture rates have gone down. And Dr. Tityal's publication on combining it with CHOPS also helps in such difficult situations. So avoid rapid buildup of hydraulic pressure, particularly when there is a pre-existing defect. Avoid forward bulge of capsule zonular complex. And I think most important is counseling the patients that you may have to change the plan from plan A to plan B intraoperatively, including the choice of IOLs. So it's not a complication that occurred which was unexpected. Thank you so much for the patient listening.
Thank you, Sahil, for a wonderful presentation and the classical videos you have. Normally we will see one such cases in maybe 2-3 years. The open posterior capsule. Wonderful surgical techniques. Thank you again.
Thank you, sir.
I'd like to invite Dr. Suvin Bhattacharjee now to talk about phaco in a small pupil. And who will be better than him, who is expert in managing a small pupil. And he's known for his innovation, the BHEX. And we all are fan of his the expanded devices. Dr. Suvin.
Good morning, everybody, and thank you, Professor Tityal, once again for this very kind invitation and honor, and those very kind words of encouragement, as always. I am going to speak on a small pupil, phacoemulsification small pupil, and I do have a financial interest in the BHEX that I'll be talking about. Now, you cannot separate IFIS and small people. They are married and they're going to live together for all their life. So, why is small pupil a problem? When the pupil size comes down by half, the viewing area for the surgeon comes down by to a quarter. It's reduced to a quarter, and that leads to vision threatening complications. Now, again, why is it a problem? Because intraoperative meiosis is unpredictable. So, there is a question always between whether it's iris hooks or pupil expanders. Well, let's address both of them. So this was a video which I presented in ASCRS and it was widely circulated. So let's look at this case where despite iris retractors, I'm having a lot of IFIS. Before I could finish my capsular axis, the iris is already frayed over there and it's looking like a fishing net over there. And then and of course, once the iris touches the phaco tip, it keeps sticking to it. So, and as I am doing my chops, the knuckle of iris over there. So this is iris hooks which could not prevent IFIS. That's the patulous iris, as you see that which viscoelastic being injected. Of course, I had to take care while I was injecting the IOL. So that is about iris hooks, and you saw IFIS with iris hooks. This is a case where I've used the B-hex pupil expander. I would like to believe that it does prevent IFIS. Well, it doesn't. You can see that knuckle of iris over there and at the main incision. So it is probably not the device which causes the IFIS or has a great role in prevention of IFIS. So how does a device help in IFIS? Now, as we know, IFIS has three components: floppy iris, meiosis, and iris prolapse. It's the meiosis part which the device takes care of. It provides a constant pupil size for good visibility and safe phacoemulsification. That's what a device is meant for. It's not for the prolapse of the iris. That depends on the severity of the IFIS and pathological damage to the iris by the device, by the disease itself. So if you have IFIS in one case with a device and you don't have IFIS in another case with a particular device, there's no credit to the device. It's just the severity of the IFIS which is different in the two cases. Now, there is another big question about whether to use a device or not to device. There are skilled surgeons, super skilled surgeons, superhuman surgeons, and different types. But just put yourself in the patient's shoes and say, if you have a 4 millimeter pupil and you are undergoing a cataract surgery, what would you like your surgeon to do? Show his heroic skills in doing a non-device surgery, or to use a device and be safe rather than sorry? So that is a thought I think you would like to spend some time. Now, these are the predisposing causes for IFIS, and as days are going by, we know the list is getting longer and longer. Hypertension itself is a risk for IFIS, and almost 80% of our patients are hypertensive when they come to the table. So there is no amount of history taking which can prevent or anticipate the risk of IFIS. So every case that comes on your table is a potential IFIS risk. Now, can preoperative dilatation in your office or OPD help you predict IFIS? Well, unfortunately, no. Even a 7 millimeter pupil runs the risk of IFIS as per this paper. Is IFIS less common in India? Unfortunately, no. It's actually much higher in India. The use of tamsulosin is much higher in India, and hypertension. This is a wonderful paper. If you have not read it, you must read it. It's a wonderful paper published in India a few years back by Shilpa Goyal and colleagues. And hypertension was identified as an important risk factor over here. Fortunately, surgeons have lowered their threshold now. More devices are available, experiences they're gaining. So because IFIS is unpredictable, as I said, we have more exacting expectations from patients and Celitis Society, as we know, and premium IOL technology is very unforgiving. So we know that. So let's get back to how did IFIS or understanding IFIS change the whole game? So Chang and Campbell told us in 2005 that non-elastic myotic pupils, unlike the non-elastic myotic pupils, the IFIS pupil immediately snaps back to its original size following attempts to stretch it. So if you want to have mechanical dilatation, it's in IFIS pupil, no amount of pupil stretching is going to help. Whereas if it's a rigid fibrotic pupil, you might get away with a controlled stretching. There are various devices. We have principally lived with the iris hooks for a long time, and then we have the rings and devices like the Mulligan ring, the B-hex, the I-ring. There are a few more other. So an important concept in small pupil is there are just two types. One is elastic and the other is non-elastic, or the rigid type. This is a concept which I actually faced when I was developing the device, and I think I promoted this, and we were aware of it, but probably we did not define it so well. And thereafter, I think there has been a recognition, and the term rigid pupil and elastic pupil has become more popular. I'm happy it's now identified. So elastic pupil is like a rubber band. Any pupil expander would work. A rigid or a fibrous pupil is like a string. You can keep stretching it, it's not going to stretch. You have to tear it. So you need to break that fibrous ring with either the device, which could be bulky, or use two Kuglen hooks to provide controlled stretching before you use the device. There is a way in which we can check the elasticity of the pupil before we start. As soon as you've made the paracentesis, inject BSS into the anterior chamber and inflate the anterior chamber. If the pupil momentarily expands, that will tell you the extent to which it is elastic. So that gives you a clue, and you now know how to go about it. If it does not budge, you know it's a rigid pupil, and it is, no amount of inflation of viscoelastic was going to help. So it might as well go ahead and do a controlled stretch, and that makes it a rigid pupil actually an elastic pupil or a stretchable pupil, so to say. So what matters most is the elasticity of the pupil and not the size. Another question which we often ask is, how large do we want the pupil to be? Now, honestly, all phacosurgeons with the kind of fluidics, knowledge of fluidics we have, or the machines that we have, if you are assured as a phacosurgeon that you're going to get given a pupil which is 5 millimeters and it's not going to come down further, I think all of us can do a surgery. So a device needs to just expand the pupil to 5 or 5.5 millimeters, and that is good enough to not damage the sphincter. You want that sphincter action also later on. Let's look at this rigid pupil pseudo-exfoliation. Thanks to Dr. Deepak Megur for this wonderful video. A little bit of stretch over there. So anything less than 4 millimeter and rigid, it's good to stretch. And the BX is being used. This is just about 5.5 to 5.75, nothing more than that. And it's a pretty hard cataract, as you can see. You can always chop it into small fragments, and that will allow you to deliver those fragments and kind of consume them with the phaco probe. And of course, this is the BX, which is very easy to insert and remove. Where do we inject viscoelastic? We need to inject viscoelastic under the pupil margin and not actually inflate the antechamber. Inflate the antechamber, you plaster the iris to the lens capsule, and actually that leaves little space for the device. So inject little viscoelastic under the pupil margin and cause a little bit of bowing so that you can have, it's easy to use your device. Now this is a BX pupil expander being used in a 1.8 to 2.2 millimeter incision. It actually goes through much smaller. I'll show you in the next video. So it's basically a little bit of viscoelastic over there, and you take the device, carry the device into the antechamber, tuck alternate flanges under the pupil margin. Under direct visualization, you don't have any guessing work as to whether it's engaged or not. And then you have a 5.5 pupil, which allows you enough room for a good capsulorhexis, followed by a very safe phacoemulsification and cortical cleanup and IOL implantation. I mean, you actually have enough visibility to do all the steps pretty safely. And you can even actually go under the pupil, under the IOL, and do your viscoelastic removal. It's no different from a well-dilated pupil. So you can do all your maneuvers, and especially if you're doing a toric lens, you would like to see those marks over there. Removal is very easy. Just grab a flange, advance it centrally, it disengages, and the trailing flanges, trailing notches actually disengage spontaneously. Now this is a 1.2 millimeter incision. This was presented at the ASCRS meeting, and you can see there. And now what happens with such a small incision is that when you hold the device across, the flange across the incision, it will not go through. So instead, if you can hold it at the notch flange junction, that the device aligns longitudinally, and it's much easier to take it into a much smaller incision. We do this again when we remove it through the side port. So that is a 1.2. I don't think a device exists other than BX which can go through such a small incision. Now you can remove it through a 0.9 millimeter side port incision. Again, that could be very useful in IFIS where you have the iris prolapsing through all ports. Just grab a flange, draw it centrally, disengage the two notches on either side, and then drag it out. No rocket science over there, no great skill required. The trailing notches just disengage spontaneously. Iris hooks, let's talk about a little bit. This is a very old video. I have not been doing iris hooks for quite some time. So we need to inject viscoelastic, and we need to just put those small nicks on the conjunctiva. Helps identify those parasyntheses that are sometimes very embarrassing. You take the hook and you can't identify it. Retract the stopper far enough in advance, otherwise again it's embarrassing. You've come to put it inside and the stopper has not been retracted far enough. I would always recommend that you don't do a full retraction. About a 5.5 to 6 is very good. Don't get carried away by the size of the pupil over here. Now keep the pupil as control as you would like to. Remember, the pupil margin now with iris hooks is always at practically the limbal plane. And moreover, often the pupil margin is anti-flexed, so that when you insert your side port instruments, you could damage it. So removing the hooks is actually very easy. Hold that stopper, advance the device, and just yank it out, and it momentarily, it's polypropylene, so it momentarily straightens. And that should be enough for the iris hooks. Now, there are certain concerns with iris hooks. Yes, I do have a bias. There are more number of incisions. Sphincter tear is more common. The way corner spaces are actually wasted. So, and like I said, it's the pupil plane is elevated, and there is a publication which says that iris hooks takes more time. Guess it's true, and of course the cosmetic damage. So a favorable pupil device in IFIS is which requires small incisions, has a low vertical profile, can exit through the side port, and so the iris hooks and the BX I think serve the purpose pretty well. let's skip this. In intraoperative meiosis, actually, it's again the devices which all exist like Malugan ring, they have a vertical profile which engages the pupil margin. The BHEX, the notches being horizontal, you can tuck the flanges under direct visualization without engaging the capsular access margin, and you have instant confirmation that you have not engaged the capsular access margin.
And welcome.
So this is Dr. David Chang had shown it in AO, and this is in the American Academy website. So choice of pupil expander, it's intraoperative meiosis, is either iris hooks or the BHEX. And in subluxated cataracts, I would definitely go for the iris hooks because you can control the clock hours where you would like better visualization. These are some resources which you have online. Thank you very much for your kind attention. Thank you.
Thank you, Suvin. Wonderful presentation. I think very, very helpful that you have shown so many techniques to make it comfortable in insertion as well as taking out, and even after the, in between the surgeries also. Sometimes other expanders are very difficult to use when you are in between the surgery and people shift to iris hooks there, but your thing can go there also. Thank you so much. Let me invite my dear colleague and friend Sun Fik Chi from Singapore. She's going to take us through the one of the difficult areas. Chi, all yours.
Okay, thank you so much for inviting me to participate in this wonderful course. So I've been asked to talk about subluxated cataract. Let me just quickly go to this. This is a manual approach. I've also been asked to address the femto approach. So the strategies in dealing with the subluxated cataract, we need to deal with vitreous, and you can see that. We do that as a first step so that we do not endanger the posterior segment, the retina. So we're dealing with it, and from a pars plana approach, because this is a really posterior subluxation, as you can see, the lens is dropping back because the vitreous that is supporting it has been removed. And that can be done with the help of triamcinolone acetonide so that we're sure that it's actually completely removed. And we are using a 27 gauge needle to bring this anteriorly. And I'm grasping it with non-tooth forceps. And I have all my paracentesis and my capsular hooks ready so that when I brought it to the anatomical position, I'm ready to hook it up. And once the first hook goes in to support not just the rim but the equator of the bag, it's now easy for me to continue the capsular access, as the hook also provides the counterforce for tearing. And in an area where I don't have counterforce, I can use my non-tooth microforceps as well. Right, so this is now easy to tear. I then insert the hooks one after the other to provide the adequate support to do phacoemulsification. Okay, so what do we then do next? After supporting this hook, you know that there is very little zonial integrity now. So the next thing to do is to protect the equator of the bag, which will still come between the hooks because it's not supported. And so the important step is to dissect the area just subcapsularly so that there's space for the CTR to be inserted without trapping the cortex. Now I'm just doing a little troughing here. This cataract is not very difficult. And then after that, I insert the IOL into the capsular bag. And this is a stage where we put in the CTR, the CTS now. We need two supports because there are hardly any zonules. And after pulling these sutures out from the Hoffman pocket, we do a 2-1-1 knot, but we don't finalize the tension until we have actually ensured that this IOL is centered, and I actually take out viscoelastic first, and then very important that this Hoffman pocket is deep enough so that the knot is well buried. And you can see this is the EDOF lens, and how did this patient do? You can see the refractive outcome, and you can see also the centration of the IOL. This patient did very well. Okay, so we go on to femto cataract. This is advantageous, especially in lenses that are not so posteriorly dislocated. It creates a centered, well-sized capsulotomy, and no countertractions needed during the capsular access stage, regardless of the anterior chamber shallowness, whether there's vitreous or not in the anterior chamber, whether the lens is slightly decentered, we can still do a capsulotomy in a jiffy. Nucleus fragmentation really helps because it enables phaco, especially when the cataract is dense, and also reduces the need for nuclear rotation as you can tumble the pieces that are pre-cut out. So let's have a look at this patient who's an adult. When he found out he actually had lens dislocations and was subsequently diagnosed with Marfan syndrome. And you can see we're decentering it and this is actually on the scanned capsular bag. I can decrease the size. All right, I generally like it a little smaller so that it's easier to place the hooks more ergonomically on the rim of the rexis. So you can see here on the table, first thing to do is to make sure that I don't get vitreous coming forward, so I inject the dispersive viscoelastic to fill up the gap that's actually present between the zonules and the rest of the eye. And very important step after removing capsulotomy, I place my hook and dissect the plane of viscoelastic just under the anterior capsule, and you can see that this needs to be done 360 degrees around, and you can insert that CTR into that clean plane. All right, you can see it skirting around, and that's not trapping cortex. All right, you can do some gentle hydrodissection. Sometimes you don't need it because you got viscoelastic there already. That's dissected off the anterior cortex, and then this is without rotating. You can just tumble the pieces out using the chopper, all right, to just bring it forward, and you can see that this piece comes out very easily because it's already pre-chopped. In this case, again, just bringing it forward. Okay, now this is completely loose. You can rotate it safely without embarrassing any of the zonules that are still remaining, and you'll see that when I remove the cortex, some may be trapped, but usually the very little trap is if you're very meticulous in the plane in which you dissect it. And you can see here really no trap cortex. All right, so it's not difficult, and it's important to put the CTR in early in these cases of very severe subluxation. All right, because that actually pushes the equator out and keeps the lens in the anatomical position. In this case, I'm doing a toric lens, and also I'm putting in the hooks that are on either side because of severe zonulitis, and Marfan's is a progressive disease, so you need to plan ahead for the patient. You want to anchor both sides so that in time to come, even when the zonules do get more stretched, they do not actually result in lens decentration or dislocation. So that's Hoffman pocket that's been created already, at least half scleral thickness, all right, diametrically opposite sides. We're just putting in a 27 gauge needle that has been loaded with a cortex suture. Use that as a lasso. You could also use microforceps to retrieve it through a sclerostomy, 2 mm posterior to the limbus. I'm just retrieving the sutures there, and you do it for the other side there. And then once you've got them both retrieved, you then tie the 211 knots, but you don't finalize the knot until you're sure that your RL is well centered. Now, if you have an RL that's not well centered, you could actually move the CTS along the equator of the lens to ensure that that lens is well positioned. So you can see that this patient did very well post-operatively. Now I'm going to move on to hard cataract. Okay, so you can see it's a very, very dense cataract. First thing to do is remove a bit of viscoelastic from the front chamber so you have some space to work in. Otherwise, you will have a burn very easily at the wound. Your CCC needs to be adequate size, but I generally would still stick to 5 mm capsulorhexis. Very important to preserve the endothelium, so you want to make sure that from time to time you're topping up dispersive viscoelastic. And what you're seeing here is that I like horizontal chops. I know Suvan does vertical chops. I find that this reduces the need to increase the vacuum, all right, because I'm basically crushing the hard nucleus between the two instruments, and this means I need less energy. I also need less vacuum. Right, but what is important is that when we start doing the chopping, you need to be deep enough, right, after having done that little short trench, that you can hold the heart of the nucleus, so that when you do your cracks, it actually goes right down to the posterior plate, and then the next action is lateral separation. Okay, now I have to move on to the next, and we'll talk about femto. This is really quite advantageous for these hard cataracts. It creates the appropriately sized capsulotomy. You can do 5.2 mm capsulotomy for these cases. Nuclear fragmentation really reduces the total phaco time, EPT, CDE, reduced endothelial cell loss, and nucleus disassembly is less effort required. But what is very important is always the plane in which you do phaco and topping up dispersive viscoelastic to preserve the endothelium. So again here you can make a larger capsulotomy, or you can just do a standard one. I generally still prefer a 5 mm. And you can see here after the femtocapsulotomy and segmentation, I don't like to really do too much of a gridding of the nucleus because I find that it's too much distension of the capsular bag with the gas that's produced during the femto treatment. I like to do 8 segments, but really with the maximum energy, a single pass. And you can see, actually, it does create a very good cut right down to the posterior plate. So you still need to do lateral separation, all right? You don't really need to do the chop. And once you've separated it completely right down to the apex, you can tumble out the first piece, and you need to keep your phaco actually deep, all right, your needle deep, so that you are away from the cornea endothelium. And as mentioned, from time to time, you need to actually top up the dispersive viscoelastic. So in this case here, you can see we don't struggle that much with this thick nucleus, because in Chinese, our nucleus can be like 6 to 6.5 mm thick, and it can be very difficult to really do that crack and to get it right down to the posterior plate. And you can see that this has been cut very, very cleanly, so we do have a very efficient phaco technique with the femto. So in summary, both subluxated and hard cataracts are more easily and safely dealt with flex than conventional phaco, but certainly it can be done with conventional methods. Thank you.
Thank you, Professor Chi. Wonderful videos as usual, and classical teaching videos. Very difficult to handle these cases, no, subluxated, and she does so beautifully, so fast also. Thank you. Let's invite Dr. Manpreet Kaur. She's associate professor in RP Center AIMS. She's going to take us to IOL calculation in post-refractive surgery patients and intraop challenges.
Thank you, sir. A very good morning to all of you. I'll be tackling the post-refractive surgery cataract, no financial disclosures. So the challenges that lie with us are preoperatively accurate biometry and IOL power calculation, the choice of IOL, and addressing patient expectations. Intraoperatively, incision management in post-RK phacoemulsification. Post-LASIK and PRK are relatively simple to manage. Phakic again poses intraop challenges regarding explant of the phakic. Post-operatively, fine-tuning of refractive outcomes and periodic periphery screening. So preoperative consideration, post-myopic PRK and LASIK, you have flattening of the central cornea. The posterior corneal surface is not affected, the anterior corneal surface is flattened. In post-RK, due to the incisions, you have central flattening of anterior and both posterior corneal curvature with a mid-peripheral steepening. So this is what is different about post-RK, and these are the issues which pose challenge during IOL power calculation. So why are there errors in IOL power calculation? One is the refractive index error, because the standard keratometrics index of 1.3375 is based on a constant anterior to posterior ratio. So once you have anterior curvature flattening, this ratio no longer holds true. Device error, the keratometry devices measure the paracentral region 3 to 4 mm and the central true flat K is not measured, so you get a false high keratometry. Formula error, the Virgin's formulas use keratometry to estimate the effective lens position. Post-operative anterior chamber depth after these corneal ablative procedure remains the same. However, the flatter K leads to an underestimation of the effective lens position. So which formula to use? We have a host of formulas. There are newer ones coming up every day. Now we have artificial intelligence in the mix. Earlier ones used pre-LASIK K and surgically induced refractive change. Then they were formula using the change in refraction only. Now we usually rely on formulas that use no previous data, because often when they come for cataract, we do not have the pre-refractive surgery keratometry values. So the newer formulas are quite accurate. 60 to 75% are within 0.5 diopters of the target refraction. Barrett True K, ray tracing formulas, OCT based formulas, and intraop aberrometry are the newer ones. So depending on can you measure the posterior corneal curvature or not, there are various formulas that are accurate, and these ones highlighted in yellow are the ones that do not require a prior history. Online calculators have made life very simple for us. We have post-refractive IOL calculator at ASCRS website, Barrett True K at the APSCRS and ASCRS website. Use these resources at your disposal. They are freely available. And when in doubt, when you're comparing two or more formulas, use the flattest K and the highest IOL power you get. So post-radial keratotomy, Barrett True K history has been found to be the most accurate. If no history is available, preoperative refraction is not known, Barrett-Truque, no history and unadjusted Haigis have been found to be most accurate. So just an example of a case comparing Barrett-Truque and Haigis. So the PAR was higher with Barrett-Truque. So we chose the flattest keratometry which was given by Barrett-Truque and the higher IL PAR. Coming to phakic ILs, they do not really affect the IL PAR calculation so much. There is a slight reduction in the ACD after phakic IL implant does not adversely impact the PAR calculation. Optical biometry is of course preferred over ultrasonic methods and use a newer generation IL PAR calculation formulae. Now coming to the type of phakic IL, monofocal, toric or multifocal EDOF, because these patients you have to understand who underwent refractive surgery in the first place have very high expectations. They wanted spectacles off when they were 20, they expect the same when you're doing a cataract surgery. Monofocal ILs should be preferred of course for myopic LASIK PRK. The LASIK PRK procedure itself induces positive spherical aberrations, so choose a IL with negative spherical aberration, which are most of the commonly available ILs. However, in hyperopic PRK or LASIK, the LASIK itself induces negative spherical aberration, so try to choose a zero spherical aberration IOL so that you do not add to these aberrations. Toric IL only in cases of post-radial keratotomy. For LASIK PRK you can go ahead. For post-RK only if you have regular stable astigmatism in the central 3 mm, repeatable magnitude of astigmatism, use at least 2 different devices to measure the keratometry, and the corneal aberration profile has to be favorable. Multifocal or EDOF, please do avoid in post-radial keratotomy cases. You can put in post LASIK PRK cases with minimal higher order aberrations and regular corneal surface, so your ray tracing aberrometry will come to the rescue to help you in decision making that can you go ahead with EDOFs and multifocals in post LASIK PRK cases. In post RK it's a no. So if you have a good corneal MTF PSF, less higher order aberration, you can go ahead with multifocal cases. Address patient expectations, always under promise and over deliver. You may have surprise even with the best of gadgets at your disposal. Intraoperative consideration. Post PRK and LASIK, of course you prefer intraoperative course is not significantly affected by the prior refractive surgery. For post-RK, the incisions, nuclear emulsification, high myopia, operating in a well-feeling and breathing pupil may pose a problem. And at end of surgery, the incision management, splicing may occur. So when you look at the RK incisions, if you look at the formula 2 pi r or pi into diameter, so depending on the number of incisions, you can get the circumference of each arc segment. So as long as you have around 8 segments, you are fine in making a posterior limbal or a clear corneal incisions. Even till 16, in between 2 incisions, you have around 2.35 mm distance, so you can go ahead with a 2.2 mm incision. However, once you cross 16 incisions, 24 or 32 arc incisions, your arc distance is lesser than 2.2 and you are going to invariably transect the arc incisions. So please opt for a corneoscleral scleral incisions or a relatively posterior limbal so that you do not transect the incisions, because slicing is going to be challenging to manage. So just a case example of a post-RK with 16 RK incisions, we used Barrett-Truque to choose the IL PAR, and OCT is a useful guide to see the depth of incisions. Anything that is going full thickness, it will open up regardless of where your incision is because of the IOP changes. And I'm making the incision in between the 2 arc incisions, avoiding transection. It's a posterior limbal incision, and these were not too deep incisions. If you saw in the OCT, they went to up to 70% depth only. The surgery is more or less similar. It's just slightly challenging because these are often high myope cases. So that is the challenge, and the reflexes distortion by the arc incision sometimes makes visualization challenging. After that, it's often said that you can avoid hydrating the incisions to avoid splicing and can just suture it. Otherwise, surgery is uneventful. This is a case in which during IL insertion, there was a splicing of arc incisions. So you have to suture perpendicular to the incision direction in order to take care of the splicing. As you can see, there is a splicing at the main incision point, and you have to suture then both the main wound and the RK incision does well in the post-operative period. Now with anterior chamber phakic IOL in situ, these are often rigid IOLs, the iris claw ones and the older anterior chamber ones, these ones are now discontinued of course, but the iris claw ones are still in vogue, and you will be getting the post-ops after 20-30 years of implantation. So OCT is a useful guide to see that the critical distance between the endothelium and the phakic IOL is maintained, and you can do a phaco with a phakic IOL in situ and explant it after surgery. This obviates the need for 2 separate incision. Otherwise, if you explant it first, you are making a 5.5 incision, you have to suture it and either go via a separate incision to complete the phaco or do an ECC SICS. If you want to do a phaco and preserve a closed chamber phacoemulsification, then beneath a rigid phakic IOL is the way to go. It is challenging of course, but the results are very gratifying and you're doing the best for the patient as well as the surgeon is also happy at having achieved only a single incision. You enlarge it after implanting the IOL, explant the phakic IOL, and a single suture does the trick. Then a posterior chamber phakic IOL is relatively easier to manage. You just have to bring the haptics into the anterior chamber, explant it via 2.8 mm incision, and you can go with a 2.8 mm sleeve and do a phaco through the same incision. It folds and comes out very easily. Not much of a challenge here as compared to the rigid phakic IOL. The rest of the phacoemulsification is uneventful. Use a hand-in-hand technique to avoid tearing these lenses because the material is very friable. Femtosecond laser-assisted cataract surgery has also been described in phakic IOLs, and post-operatively do consider a retinal screening. In post-RK cases, there may be delayed visual recovery or hyperopic shift, and light-adjustable IOLs can be done. Intraop aberrometry can help you if you get IOL surprises despite the best of calculations in some challenging cases. So to summarize, biometry is challenging, IOL power calculation, prefer monofocals, toric and regular astigmatism, avoid multifocals in post-RK. Intraoperatively, incision management is a challenge in post-RK cases, and phakic IOLs have to be tackled before you can proceed with phaco. Post-operatively, delayed visual recovery may be present. Counsel well, under promise and over deliver. Thank you for a patient hearing. We conclude this instruction course. I think we have slightly run over the time, and we hand over to the next set of speakers.